In this video, we'll talk about hypertension, which is a iceberg disease. So the incidence has a little value because of the variability of consecutive readings. So one time you measure, it will be around 120 by 80, and another time you measure, it will be around 140 by 90 or something like that. So what is the normal value? What should be considered is confusion, right? So because of which the incidence has a limited value. And now coming to the global prevalence. So around 1.13 billion people have this hypertension, around which 10 million people are getting killed by hypertension every year. And hypertension progressively increases along with the age. 60% of cases of hypertension are seen above 60 years. In India, it is considered to be hypertensive when the BP is above 140 by 90. And coming to prevalence of hypertension in males and females, so it varies according to age, right? So first, up to first 50 years, the females are having less BP compared to males. After 50 years, because of the postmenopausal age, females are having high BP compared to males. Now coming to classification of BP, we have two classifications. One is classification of BP measurement and second is classification of hypertension. Coming to BP measurement, we have 7 subcategories. One is optimal, second is normal, third is high normal, grade 1, grade 2 and grade 3, and then the isolated systolic hypertension. Let us talk about 2 categories at a time, right? For the optimal and normal, the systolic is less than 120, less than 130 respectively, and the diastolic is less than 80 and less than 85 respectively. Coming to high normal and grade 1. 130 to 139, 80 to 89, 140 to 159, 90 to 99. So these are the values. Coming to grade 2 and 3, for grade 2, it is greater than 160 mmHg and grade 3 greater than 180 mmHg. And for diastolic, it is greater than 100 and greater than 110. Isolated systolic hypertension means if the BP is equal to or above 140 and less than 90 mmHg. That is isolated systolic hypertension. So these are the different categories of blood BP measurement. Higher the BP, higher the risk of developing complications like stroke, coronary heart disease, etc. Now coming to classification of hypertension, it can be primary or secondary. Secondary is because of other diseases and it occurs in less than 10% of cases, like in case of chronic glomerulonephritis, chronic pyelonephritis, adrenal gland tumors, toxemia of pregnancy, congenital narrowing of aorta. So these are the different cases where you can see secondary hypertension. But the primary is an essential hypertension and the cause is usually unknown, and it is a most prevalent disorder seen in 90% of cases. So tracking of BP. What is tracking of BP? BP levels are checked over a period of time from early childhood to the adulthood. So this particular thing is called tracking of BP. Lower BP tends to remain low even as the age progresses, and higher BP tends to get higher as the age increases, right? So this phenomena of persistence of rank order of BP is called tracking of BP. So what is the importance of it? It is used to identify the children or adult who are at the higher risk of developing hypertension in the future. So what happens if in the early childhood the BP level is higher, most likely to develop hypertension in the future also, because the higher BP tends to get higher, whereas the lower BP tends to get lower, right? So this is the graph you have to draw. BP progresses as well as the time. BP on the y-axis, time on the x-axis. Now coming to the rule of halves. So what is happening here? People are having hypertension, right? Half of the people who are having hypertension are aware. Like only half of the people are aware, and even in that half, only half of the people are taking treatment, and even in that half, only half of the people are taking adequate treatment, right? Suppose 100% are people with hypertension, only 50% are aware that they are having hypertension, and only in the 50%, only 25% of the people are taking treatment, and even in that 25%, only 12.5% are taking adequate treatment. So this is the rule of halves. The proportion of treated people will be less in developing countries compared to the developed countries, as we all know. And this is the diagram you have to draw. In the first circle, you have 1 on the circle and 2 inside the circle. In the second circle, you have 3 on the circle, 4 inside the circle. And third circle, you have 5 on the circle, 6 inside the circle. And likewise, on the fourth circle, you have 7 on and 8 inside the circle, and the 9 is at the middle. So the first indicates the whole community, and the second indicates normotensive people, and the 3 indicates hypertensive. And even in the hypertensive people, some will remain undiagnosed and some only get diagnosed. Even in that diagnosed, some will not take treatment and some will take treatment. That treatment, some will take adequate treatment, some will take inadequate treatment, right? 4 stands for undiagnosed, 5 stands for diagnosed. After the diagnosis, some will take treatment, some will not take treatment. So 6 stands for no treatment, 7 stands for treatment, and even after the treatment, treatment will be adequate, treatment will be inadequate. So 8 stands for inadequate, 9 stands for adequate. So these are the rule of halves. You have to write about this diagram and what does this numbers indicate. Now coming to risk factors. First we'll talk about non-modifiable risk factors, then we'll come to modifiable risk factors. The non-modifiable risk factor is age. So BP increases as the age increases because of accumulation of environmental influences and effects of genetically programmed senescence in the body systems. And sex also. So in the adolescence, like below the age of 50 years, men will be having more BP compared to women. But greater than 50 years, because of the postmenopausal age, women will be having greater BP than men. Coming to genetic factors, it is based on the polygenic inheritance, and twin studies have shown that monozygotic twins BP will be correlating. That's right, normal 3% chance, hypertension 45% chance. It is nothing but if the child is born to parents who are normotensive, both the parents are normotensive, then the child will be having 3% chance of developing hypertension in the future. Whereas if the child is born to hypertensive parents, then he'll be having 45% of chance to develop hypertension in the future. Ethnicity. So black communities will be having higher BP than the white communities. Coming to modifiable risk factors. One is obesity, central obesity. That means the waist by hip ratio is higher, indicates high BP. And salt intake. If the salt intake is greater than 7 to 8 grams per day, then you will be having more chance of developing BP. And also genetic abnormality in the essential hypertension will lead to less salt excretion. So salt will be retained in the body, leading to higher BP. Potassium, calcium, cadmium, magnesium, these ions will help in reducing the BP. Mainly this potassium works by antagonizing the sodium and decreases the BP. Saturated fat also increases BP and also increases cholesterol. Dietary fiber decreases the BP, as shown to decrease LDH, cholesterol, and also shown to decrease CHD. Alcohol increases the systolic BP, and smoking, stress, these are the main cause for hypertension. And physical activity, it has an indirect effect in decreasing the BP, because when you do physical activity, it decreases the weight and decreases the obesity, which decreases the BP. Socioeconomic status. In countries who are in the post-transitional stage, those socioeconomic status people are more prone for hypertension. Whereas in the countries with pre-transitional or the transitional phase, the people in upper socioeconomic status are prone to hypertension. So secondary causes of hypertension will be oral contraceptive, because of the estrogen component present in the combined pills, and also noise, vibration, temperature, humidity can also cause secondary hypertension. Coming to primary prevention. So we have primary prevention and secondary prevention. So what are we doing in the primary prevention? We are not letting the person develop hypertension. But if the person develops hypertension, we are controlling the hypertension, and also we are preventing the risk of complications in the secondary prevention. All measures are to decrease the incidence of disease in a population by decreasing the risk of onset. So we are not letting the person develop the hypertension by population strategy. So the approach is based on even a small number of reduction in average BP of the population would produce a large reduction in the incidence of cardiovascular complications. For this, we'll have to educate the people on proper nutrition. We have to decrease the salt intake less than 5 grams per day, and moderate fat intake should be taken, and avoid high alcohol intake. Weight reduction also helps. Maintain the normal BMI is very important, as it decreases the risk of CHDs, and exercise also decreases the weight, it decreases the BP and also blood lipids. Behavioral changes like controlling the stress, not smoking, changing the sedentary lifestyle to an active lifestyle, including the yoga, meditation in the daily routine will be helpful. And health education is important for prevention of risk factors of hypertension. So we have to explain them about the treatment, what happens if they do not take the treatment. We have to explain about the complications also. So the last thing is self-care. So the person who is at the risk of developing hypertension should maintain a logbook which has the BP measurements taken every time. So he should track his own BP. It would be helpful for him as well as the person who is treating them. So this is about the population strategy. We have to focus on nutrition, weight reduction, exercise, behavioral changes, and health education. Coming to high risk strategy, it is to prevent the attainment of BP at which the institution of treatment would be considered. Familial history of hypertension will be considered, and then you have to track the BP from early childhood to adulthood, which helps in identifying who are at the risk of developing BP and treating them properly, and giving them early treatment will be very helpful for them. Right? So this is about high risk strategy. We have to find people who are at the high risk, and we should initiate the treatment early. To secondary prevention, if we have failed to prevent the disease at the first place and the person has hypertension now, right? First, we have to detect and control hypertension as early as possible. And second, we have to decrease the risk of complications. The point is early case detection. How will we detect case? We have to screen the whole population. But it wouldn't be effective if you do not have any resources for the treatment and the follow-up. So if you have proper resources for the treatment and the follow-up, then you should go and screen the whole population, and who are at the risk of developing hypertension should be given treatment and also should be followed up. Coming to treatment. So what is the aim of the treatment? It is to maintain the blood levels in the normal range, like 140 to 90, or ideally it is around 120 by 80. It reduces the incidence of complications, and attention should also be given. You have to also educate the patient on the risk factors like smoking, high cholesterol, obesity, etc. So hypertension rarely causes any symptoms until the organ damage. So it is very important to detect it early by screening the people. Also to give a proper treatment to prevent the complications like stroke, ischemia, etc. Patient compliance. See, the medication for hypertension is for the lifelong. So that is why the patient compliances might not be good. Compliance rates can be improved through the education of the patients, family and the whole community. So this is about hypertension. Bye.